To this video reviewing the use of the NEOT device. So the NEOT device is a single-use multifunctional device used for providing ventilations or respiratory support in the form of CPAP to neonates or infants instead of using our standard BVMs. It's an oxygen-driven and pressure-limiting device that allows us precise control of peak inspiratory pressure, so our PIP, and positive end expiratory pressure, or our PEEP. So we have full control of the amount of pressure going into the baby and how much pressure is left in the baby's lungs after we've given those breaths. So indications for use for this device, it's any neonate or infant less than 10 kilograms or less than 22 pounds that requires assisted ventilation or CPAP respiratory support. So reasons we'd want to ventilate our babies, obviously if they're not breathing, that's kind of a big deal. So we're going to start assisting ventilations. They're gasping or ineffective breathing, we're going to give them assisted ventilations, or if they've got a heart rate below 100, so we're going to start assisting ventilations. So with that, as per our guidelines, you need to begin PPV if needed by the 60-second mark. So our baby's been born, we did our assessment, we tried to stimulate, all that good stuff, and none of it's working. We're going to start looking at ventilating our baby. If the heart rate is above 100, we're going to continue PPV until baby's spontaneously breathing on their own, and then we can gradually wean them off. And we're going to keep an eye on their breathing rate and their heart rate. Big thing to remember is when we start with assisting ventilations with these patients, we're going to be using room air. So we're not going to be using any supplemental O2 because sometimes these babies just need a couple extra puffs to stimulate their breathing. They haven't breathed on their own yet. They've always been dependent on mom. So we want to try and get them breathing on their own. So those couple puffs could be all they need to open up the lungs and get them breathing on their own. So we don't want to get too aggressive with our oxygenation right away. If that's not working for us though, and their heart rate is between 60 and 100, we're going to keep ventilating till we get their heart rate above 100. And if that's still not working for us, then we're going to start looking at adding some supplemental O2 at about 10 liters and target their preductal SpO2, which we'll cover in a second. And we're going to keep reassessing to see if the baby's heart rate picks up. If the heart rate stays below 60, we're going to start ventilating our patient while we do chest compressions. So we're going to begin compressions at 120 a minute and continue our positive pressure ventilation with 100% O2. So now we're definitely adding supplemental O2 if we haven't already. And our compression to ventilation ratio is 3 to 1. So it's 1, 2, 3, breathe, 1, 2, 3, breathe. And we're going to keep doing this until our heart rate gets above 60. And if that's not working, we're going to start sitting more definitive airway, and then we're going to look at other reasons why this baby might need resuscitation after that. So the big thing is with the NEOT here, it does require oxygen to work. So it's going to take some time to set up. So if your baby's apneic, their heart rate's low, don't not do anything while you're setting this up. We're going to start BVMing them right away, especially with room air, to start there while we're setting up our NEOT. So it's going to be like a two-person activity here. So one person's going to have to start ventilating the baby while someone else gets the NEOT set up. We got to make sure our baby's getting oxygenated. So we also, the big thing is it takes time. So we want to make sure our pressure gradients are set properly. So we want to make sure we're taking that time to do that because obviously if the pressures are off, that could be detrimental to the baby as well. So the actual parts of the NEOT here, so we have our oxygen port, that's what attaches to our oxygen tank. We have our inspiratory pressure dial, and that decides what our level of PIP or positive inspiratory pressure is. We have our PEEP dial, which we adjust to determine how much PEEP we have. And we have our ventilation hole, so that's the hole we actually cover to deliver a breath. So every time we cover that little hole there, that's going to give a breath at the amount of pressure that we determined with our PIP. And it's the pressure manometer is going to show us how much PIP we're giving, and it's also going to show how much PEEP is left after we're done with each breath. So when it comes to PIP versus PEEP, so like I kind of mentioned, so our peak inspiratory pressure is the amount of breath that is being pushed in. So as you can see in the picture there, the hole is being covered. We've got that pressure gradient. Our PIP has been set for inspiration. So every time we cover that hole, we give whatever the pressure gradient of inspiratory pressure is that we set, and that's how much the baby's getting in. When we look at release the hole, we release that positive pressure. Now we go to our positive end expiratory pressure, so that's the amount of pressure left in the lungs, and this is held in set at the pressure gradient that we set it to when the baby's exhaling. Okay, so PIP is how much air is getting pushed in. PEEP is how much pressure is left in the lungs after we have stopped that ventilation. So to set the pressures, so we want to set the pressure to 20 centimeters of water pressure for our babies. So realistically, we're going to set the dial there, as you can see on the right with the blue dial. We're going to set the little triangle in between the green and the yellow, and that'll get us to about 20 centimeters of water pressure. It does mention that if this isn't working for you, you can titrate it up a bit. So we can just adjust the dial, but make sure you're watching on your manometer there, how far you're going, because we don't want to go past 40. That's quite a bit of pressure. So we don't want to be causing barotrauma. And this is the nice thing about this device. We have a lot more control over that amount of pip versus like a BVM, which the pip's whatever we squeeze the bag at. So this gives us a lot more control. Setting our peep, so there, like I said before, there's a little peep dial here, so you can increase it, you can decrease it, and this is the pressure held after exhalation. So with that, when we rotate the dial, we want to make sure it's set to 5 originally, and again, we may need to increase the peep or the pip based on how our patient's responding to our therapy. So the max peep we want to go to for this patient is 10. So as you can see, the dial goes all the way up like pretty high, so but we're not going to go any more past 10 because that can be detrimental to our patients. So we're going to top out there. So the first thing we're going to do when we set this thing up is we're going to attach our auction and set it to 10. We have to have the auction set and going so we can dial our pressures in appropriately. We're going to make sure the red test cap is applied to the end of the device. So where the red cap's sitting, as you can see in the picture there, that's what's going to actually attach to the baby. So we're going to block that off because that'll tell us our pressure gradients, because we obviously want to do this before we put it on our baby, because the last thing we want to do is start ventilating our neonate and find out that our pressures are way too high. So once we've got that applied, if it's not already attached, we're going to include the ventilation hole and set PIP to 20 centimeters of pressure. So again, as I said before, you're going to rotate this. You see a little bit of blue part goes in between the green and the yellow. And when we push that, cover the hole on top of the PEEP adjuster there, that should be how much pressure is being put into our baby. Okay. So as you can see here, I'm going to adjust my PEEP. Right. I'm going to rotate that dial to set it to 5. So again, I want my PIP starting at 20, my auction set to 10, and my PEEP set to 5. So again, 5, 10, 20s are the numbers that we need to remember when we're setting this device up. Okay. So with that, we've done all that already. Then we're going to attach the appropriate mask, or we could attach it to an iGel if you've decided to go with an advanced airway because you have concerns about their airway. We can attach it to an iGel. If you're doing an IFT, you can attach it to an ET tube. It depends on how you're choosing to maintain the airway of your baby. So with that, speaking of ventilating our baby, we want to make sure that we align the head and the airway as best we can. So we want it horizontally aligned. So we want it in a nice neutral or that sniffing position. So again, as you can see here, we got that shoulder roll, we got a nice headrest. We want to make sure we're opening up that airway as best we can. This is really, really important. We need to keep that trachea open because obviously if we're pushing air and the trachea is blocked off because their head's pushed forward because we didn't align it, we didn't put that towel roll underneath the shoulders, this isn't really going to work for us. So we always want to make sure we're looking for rise and fall of the chest, and also just the ease, like are we getting a lot of excessive pressures, things like that. We got to make sure we're checking that airway. So as you can see here, with each breath, you cover the hole. You got a PEEP of 5, a PIP of 20, PIP of 20, PEEP of 5. So every time we see it as you go, it's every breath. So we want to maintain that, and to do that, we need to have that open airway. So if we're having trouble ventilating our patients, we want to go to our Mr. SOPA troubleshooting. So we want to make sure we got our good mask seal. So again, like I said before, we got to make sure that the head's in a good position. So that's kind of the reposition the airway. The big thing, those two kind of tie together because sometimes we try really hard to get a good mask seal. And to get a good mask seal, we push down on the head, which pushes the chin forward, which blocks off the trachea. So make sure that you're maintaining a good seal without pushing the head forward because that's going to affect your airway. So reposition the airway, get a good seal. I like the idea of bringing the face to the mask instead of pushing down the mask to maintain a seal. So we got to get that taken care of. Okay. If you find that you've got an infant you're using the NeoT on and it's not getting a good seal, it does come with a neonate mask as well. So maybe you need a smaller mask. So you could try that as an option if you just can't get a seal with the infant mask. Suctioning is an option. We want to look at secretions. Do we need to use wall-mounted suction, which for little ones might not want to. It's kind of aggressive. If it catches their airway, it can cause damage. You got to do what you got to do though, but if you can get away with using the bulb syringe, that would be preferred. Obviously, we're going to increase pressure. We talked about it a bit. So sometimes you need to just increase your PEEP to just help recruit more alveoli to get better surface area for gas exchange. Or you might have to increase your PIP because you just need to get more air into their to get more oxygenation of your baby. And if none of this is working, then we can start looking at an I-gel. Like if the airway's just not working for us, there's copious secretions, there's something going on that's stopping us from able to get breaths in, we can look at putting an I-gel in. The big thing, again, you have to keep in mind is that if you have an I-gel in place, that doesn't protect your lower airways. So that neutral position of that trachea is still very, very important, because if their head's still going forward, even with an I-gel, it's going to kink off the trachea, and that's not going to work. So again, that inline maintenance of the trachea is very important, whether you have an I-gel in or not. So these are just some of the things that we could look at for dealing with our difficult ventilation of our neonates. So if we're not PPVing, but we're going to use CPAP, so the indications to use CPAP is if there's labored breathing, persistent central cyanosis, or persistently low SpO2 despite supplemental O2, we could look at using CPAP. So with that, it's more so to support their ventilations as opposed to us taking over for their ventilations. So as you can see there, it's got I talked about it a little bit earlier, we got that target preductal SpO2. So if your baby's like at a couple minutes, they're pretty new, they haven't used their lungs yet, they need oxygenation. Like if they've got a SAT of 70, that's not horrific. But if you're at 10 minutes, their SATs are at 70, we need to do something else to support them with their oxygenation. And if their breathing's pretty, like a regular rate, it's just kind of labored, we can look at using CPAP because that's more direct. So the way to use the CPAP is basically we just put it on their face, we don't cover over the hole that we use to give the breaths, and they just get that pressurized O2. So with that, again, if their heart rate's less than 100 or the patient's not spontaneously breathing, we're just going to go back to breathing for them. The really nice thing is that with this device, if we're using it for CPAP and we notice that their respiratory effort's decreasing, we can just go straight to PPV by starting to cover that hole again and giving them positive pressure ventilation. And if that gets their heart rate up, gets their breathing rate up, but they still need oxygen support, we can still just leave it on and give them CPAP. So we can move back and forth very quickly, as opposed to if we're using a BVM versus other oxygen delivery devices. Another thing as well is when we do look at the target preductal SpO2, we have to make sure the SAP probe is on their right arm, because we want to get a reading of their blood before it hits the ductus arteriosus, where the oxygenated and deoxygenated blood go in the heart, because their valves are still going to be open from being in utero. So that'll give us the most accurate reading. So again, when you're putting the SAP probe on these patients, it needs to be on the right wrist is the best place for that. So set up in the NEOT for CPAP. So I kind of mentioned this. So with that, we're going to set it up exactly the same way. If you're just using it just for the CPAP, we're going to make sure that we check all our pressures. We set everything up correctly. This one more so is just CPAP. We're not so much worried about our PIP. Not a bad idea to set it anyways, just in case you do end up having a PPV, it's all set up and good to go. But we're going to make sure our PEEP is set to 5 first, and then that way we can just support the ventilations. Then we're going to take the appropriate size mask, apply it to the patient, or if they have an I-gel, we can attach it to the I-gel and give them CPAP that way as well. Big thing just to add, whether you're using this for BVM, for either for PPV or for CPAP, if you want to use end-tidal CO2 on an I-gel, make sure that it's the I-gel, the end-tidal CO2, and then this sits on top of the end-tidal, because obviously you're not going to get an end-tidal reading if you put it on anywhere else in this circuit. So we always want the end-tidal as close to the patient as possible, so you get the most accurate end-tidal CO2. One thing as well, make sure you're using the right end-tidal CO2 device, because if you put an adult CO2 device on this neonate, you're not going to get a reading because their lungs are just so small, you're not going to get an accurate sample, and your end-tidal is going to be incorrect if you get any reading at all. So something to consider as well. Thank you very much, and have a good day.